The fact that it brings this up.
Yes. them to come up. Very good. I'm told we're good. So come on up. If you can introduce yourself and maybe give a little bit of background before you jump into the report, I think that'd be helpful.
Absolutely. My name is Melanie Ingleby with Siegel.
Real quick, is your microphone blue?
Like to you?
Yeah, okay.
Okay. Melanie Ingleby with Siegel. Pleasure to be here with y'all this morning. I apologize I wasn't able to be here last time. I had a family emergency, but very grateful to be here with you today. A little bit about myself. I will be working as a lead actuary going forward. I have 12 years, a little over 12 years of experience as a healthcare actuary. I started my career at a university-affiliated integrated health system, and then for the last 6 years, I was the chief actuary at the Teacher Retirement System of Texas before joining the Siegel team last June. So a little bit about myself. And as the Secretary mentioned, I will be presenting the financial report for you all today. One item of clarification, am I supposed to click through it, Ben, just so I know?
I can click through for you.
Okay, that would be great. I just wanted to make sure we have that business settled and that I didn't miss that if that was on my plate. Okay, so as far as the financial report goes, we have a few items to discuss today. We have data for December. So we have the 2025 actuals, we have some historical trend exhibits, and then the updated multi-year projection. Starting with the 2025 actuals. The reserve balance at the end of 2025 landed at $37.5 million. This is slightly higher than the $37.2 million that was projected at the last meeting. That's primarily due to program revenue, which was offset to some extent by increases in expenses. We did see medical claims came in slightly higher than last projected. RX claims came in slightly lower. Those mostly offset one another for a net loss of $300,000. Your other expense lines continue to track relatively close to the last update, relatively close to your budget, with the result being a $12.6 million net income for the year. As you know, that's heavily influenced by that $14.6 million ZRX payment for 2025, without which the net income would have been negative $2 million and the ending reserve balance $22.9 million. Looking at the historical trends, for enrollment, we've seen increases in enrollment over the last 3 years, including in 2025 with a 1.1% increase. We'll get there in a minute, but you're also going to see a slight increase in your 2026. The 6-year effective trend for enrollment is just slightly negative at negative 0.1%. For both medical and RX claims, we show your trends mapped with the Siegel Health Plan Cost Trend Survey to give you a feel for what we're seeing in the market in the same year. The trend was 4.6%, which is below what we saw in the market and is also below the 5.5% that we use in the projections. The 6-year effective trend is 5.2%, which is very close to that model trend. Moving into the pharmacy, the 2025 pharmacy trend was 9.6%. This is above the 8.5% that we use in the projection model, but below what we saw in the market. As you can see, pharmacy trend a little bit all over the place, not unexpected as it's heavily influenced by things like PBM contract changes and GLP-1 utilization. And the GLP-1 utilization did contribute, to that 2025 trend. And I know that that's an item that's going to be discussed next, but we did see that contribute to that trend. Your effective trend for your pharmacy was 7.1%. For dental claims in 25, trend came in about 8%. There were material plan changes. Wasn't too far off from the expectation of the budget. It's about $700K over budget, but the 6-year effective trend remains low at 1.6%. Excuse me. Looking into the enrollment, 2025 enrollment landed right, about where it was projected. There was some movement, slight decrease in Medicare lives, offset by an increase in non-Medicare lives. But the net difference is 15 subscribers, so quite close to where we started. We also have a snapshot of the January 2026 enrollment. Like I mentioned, we do see a slight increase in January 26. Well, with that same dynamic, we have a decrease in the Medicare lives, an increase in the non-Medicare lives, and that increase in non-Medicare lives does still result in a net increase. As far as the multi-year projection, you will see we've added calendar year 2030, so that we have the year we're currently in, calendar year 26 now, as well as 4 years out, and we have the updated projection year for calendar year 26. Updated reserve balance projection for the end of 26 is 24.4 million, slightly down from the 25.3 million that was projected as of the last update, and that is due to an increase forward, came in slightly higher than the last projection, and that is influencing that projection in 26 and going forward. You'll notice that in 27, the new reserve balance projection is $13.3. As far as how this affects the funding rate increases, the funding rate increases were moved out to 2030 as the target year. And as a result of that, with the 8% employer, 2% employee in 26, the model projects a necessary funding rate increase of 7%. That is primarily, that's a drop from the 7.8 that we discussed last time, but that is due to the extension of the target from 29 to 2030. In the table below, we show that if the target year was 29, 7.9%, slightly above that 7.8 that you saw at the last meeting. Multi-year projections are always sensitive to trends. In the next exhibit, we show the impact to the reserve balance should the trend are 1% worse than the assumptions. Starting with calendar year 27, as we discussed, the expected trend results in a $13.3 million reserve balance. If that trend were 1% worse, it would be negative 4.2 in that year. 1% better would be 30.7. So as you can see, even just 1 year out, that 2% spread in trend creates quite a spread in your reserve balance. Further out to the 2030 balances, that spread is larger with 1% better trend resulting in a reserve balance of 171.1 million and 1% resulting in a negative. And in that worst scenario, you need approximately a 14.4 achieve the target reserve balance at the end of 2032. We also have the chart showing the sensitivity to the funding rate to $1 million. So this would be a $1 million gain or loss in the budget projections starting in 26, and then it in the projection at $1 million would result in a plus or minus 0.1%. That concludes what I have, but I'm happy to answer any questions.
Very good. Thank you very much. Commission, any questions? I have one. The last point you just made about the plus or minus $1 million in the funding rate sensitivity, I assume that's not linear. Is it really $1 million for every 10th? Like if it was a $5 million increase, is it?
Roughly, but it would, yeah, I mean, it's not going to be exactly linear, but the relatively approximately.
Okay, thank you. Any other questions? All right, hearing none. Thank you very much. We appreciate this. All right, Commission. Next order of business. I don't believe we have any materials on. There's a label in tab 3. This is really just a discussion on GLP-1 restrictions. As you might recall, during I think it was last June's meeting, pardon me, as we did plan design changes for calendar year 2026. We did put the new restriction on GLP-1 for anti-obesity medication utilization. We made no changes to those with diabetes, right? Left that alone, but we did put a baseline of 35 of BMI to be approved for a prior authorization. So there's been a little discussion about how this was implemented and what the technicalities are around that and how that works. I thought it'd be a good idea just to make sure everybody's on the same page. I'm going to invite Caremark to come on up to the microphone, CVS Caremark, to explain to us how the PA is working and run through a couple of different scenarios just to ensure that we're all on the same page. So if you could go ahead and introduce yourself to the committee and make sure your microphone is on before you do so. Just walk us through how this is working, please. Is the light on?
Yes.
Okay, very good. Thank you.
Good morning, everyone. I'm Ryan Hermers with CVS Caremark. Yes, one. I think we wanted to first off state what we implemented was what was quoted as far as the savings when this hours worth of savings when it was presented and voted on in June. That's what is implemented now. Talk about the nuances of how things are going. So I'm going to run through 3 or 4. So I'll try to give dates and all of this right now. Right now, brand new member, never had a prescription filled for anti. Walks into the pharmacy, they have to go through prior authorization. Their BMI, as attested to by the doctor, with chart notes that we record. Prior authorization. The BMI is 35 or higher. They are approved for their initial. Is 35 or below, I say 34 or below, they will be denied through our prior authorization process. Running exactly right now since 1.2. Our notes, they also give us their weight, to us to weight now. Yeah, some of the scenarios there. About that.
Why don't you go ahead? Why don't we, if it's all right, Commissioner Kane, if you can, so it's clear if you have a 34 or below that you're denied the PA. There is an appeal process, but that's the baseline. If you can walk through the next, the PA process at the renewal date for the member that was at 35, and then we'll come back to questions.
Remember, that same member walks in, their BMI is 35 or higher, they get approved. We'll say their baseline weight, as documented to us, the doctor was 200 pounds. We'll see that. I was 35 or higher, they weigh 200. The BMI then drops to lost weight. Question is, what are the requirements at that point? So what would happen is, we look at their initial the doctor tested to. Doctor tested their baseline was above or equal to 35. So we go to the next question, and that would be the weight loss sheet. I mentioned that member weighed 200 pounds, so that member would get reapproved on the medication if they had lost 5% of it. So that member, even though their BMI, their baseline BMI will be over 35 and they got approval, that dropped to.
Okay. Thank you. And then it dropped to 35, it dropped to 34 at reapproval. Since their weight went from 200 pounds to below 190 pounds, which is 5%, they would get reapproved.
Say that again, please.
Sure. So if you're approved for a medication, the doctor attests right away your baseline BMI is 35 or higher. When it goes up for reapproval, so the prior authorizations expire, we're staying on this medication. You drop from a 35 to a 34 or 33 BMI. a year from now. So that's not an immediate disqualifier of refilling the medication. We would look to see what their weight loss was. In this instance, when the member weighed 200 pounds, they'd have to weigh less than 190 pounds as attested to from the doctor. So they know if they've lost 5% of their initial baseline weight from this year. So if you carry that forward, they're approved today, and then they get a reapproval, we'll say next year, they would have to have lost 5% from that 200 pounds from today.
Let me start with Commissioner Kane first, and then we'll go to Commissioner Sutton. Did you have a question? Sorry, we're going to pause there. Go
I
ahead.
did.
Sure.
Back to just the BMI of 34 or below or 35 or higher. If it was 34.5, would it round up to 35? So it's like if it's 34.9, then they don't qualify.
Correct, yeah.
Okay,
It's
thanks.
35 or higher. Mhm.
Commissioner Sutton.
Thank you, Mr. Chair. I get the 35. We decided that here. The part I'm missing out on is where did the 5% come from?
Sure, that's part of the continuation of therapy, and that's part of the requirements with the BMI 35 criteria. So
Was that something that we did? I don't recall that part.
the purpose of this meeting is to discuss that because was what was implemented.
Oh,
So,
gotcha.
Yeah. So, and it's a good question. That detail was not discussed in the June meeting.
Excellent. All right. Thank you. Thank you, Mr. Chair.
Commissioner Schmidt.
Okay, you went in your introduction, you're the director of the pharmacy. So are you a pharmacist?
No, I'm not.
Okay, interesting. Okay, so that is not what the motion said. That is not what the intent of the motion was. I do not believe, and I've listened to the recording of our December meeting, and we even talked about grandfathering and things, and we said no. I mean, so in reality, a person that has a BMI over 35 goes in today, is approved for a GLP-1 for weight loss. I mean, we're not talking about diabetics. We're just talking about weight loss today, or at least I am. Then they could perpetually have, they could have a PA forever, the rest of their life.
If they maintain that initial weight loss from the 200 pounds, that scenario. So I had it played forward.
So they lose 5 pounds or 10 pounds and then they're approved the rest of their life. They can have a BMI of 22 and they can be approved for the GLP-1. Would that be a correct
If the
statement?
doctor attests at every PA that their baseline BMI was greater than 35, we would go back to the initial weight at the start of therapy. And if they had lost 5% from that 200 pounds, so 189 pounds they'd have to weigh. But if they did not lose that weight or did not maintain that, then we would deny it. So if you play it forward, if
That 5%, they only have to maintain the 5% weight loss. Even if they're 400 pounds and they lose 5%, and then they're a BMI of 24, they can continue to be on GLP-1s.
they could, yes.
That is not what the motion said. Where were you when we were discussing this? We had a lively discussion, and Caremark, you guys should be here every meeting when we're discussing PAs. So where were you guys?
Hi, Rick Edwards. I'm the executive director of our government business unit with Caremark. Been there 25 years, so happy to be here today. I was at the meeting in June. Brian was not on the account at that time.
You were physically
But I
here?
was physically here at the meeting in June. It was not, the continuity of therapy component was not discussed at that June meeting, but I can reiterate what Brian said, that the value that was proposed as far as savings was based on that continuity of therapy component being part of that program.
So
And
where,
that is a manufacturer requirement. It's not our requirement, it's a manufacturer requirement.
but we don't work for the manufacturer.
I understand.
We work for the people of the state of Kansas here.
I understand.
And we are the ruler of the PAs here. I mean, do you have any other, are you a pharmacist?
I am not.
Do you have any pharmacists here today?
I do not believe our pharmacist is here today.
Why?
I think she had a
I
conflict.
should be able to talk to, she had a conflict? I have a lot of conflicts in my life right now, but I'm here.
I understand.
Why would you not bring a pharmacist? It's a simple question. How many pharmacists do you employ?
Thousands.
Thousands? How many thousands?
I don't know the total number.
You're government affairs, right? You should know your numbers.
I don't run government affairs.
Pardon me?
I do not run government affairs.
What did you say your title was?
I'm an executive director within our government business unit.
Government business unit. Okay, perfect. Well, you should still know your numbers of how many people you have as pharmacists, because it's tens of thousands, isn't it?
It is.
And you can't find one to come with you.
I apologize.
Okay, no, don't apologize. It's ridiculous. All right, I'll move on. So no one in June stood up. You were here in June.
Correct.
And you didn't stand up in June and talk about that when we were talking about GLP-1s and the increase.
We did not. And in hindsight, that was an error on our part.
You what?
In hindsight, that's an error on our part, but we did not.
Well, that's millions of dollars of error in your part. So my calculations are that in 2025, well, I should ask, we received 2025 numbers, pharmacy numbers from through the end of the year today, Siegel, right? Okay. Do you have the GLP spend through the end of the year?
If we can, 1 second, Commissioner, I'm sorry to interrupt. If we can have one conferee at a time and then.
Okay. I won't ask that, but our GLP spend through September of 2025 was 14 million, and that was up from 2024 of $9 million. And I do not know if half of that GLP-1 spend was for weight loss, we would have been in the black in 2025 with the PA process that we set up, that we thought we were setting up, that you do not apparently think that when we set up something, we mean it, right? Because in December, we said, if you have a BMI of 35 or above, and you're not a diabetic, you can have the GLP-1s. But as soon as you pass 35 and you're at 34, you do not qualify for GLP-1s. The way you've set it up, once you're at a GLP-1 of 35 and you lose 10% of your weight, you're on that forever. Do you have any other PAs that you institute that way? I can't think of another drug that you would do that with.
I do not know the answer to that question.
I mean, I think about growth hormones. We make pediatricians that put kids on growth hormones have a yearly check. It's a long yearly check, right? And those kids aren't, and the majority of those kids are going to be on that for a long time, but we still make them do that. And now you're just saying, man, you lose that 5%, you're golden for the rest of the time. That's not what we intended. Anyway, okay, if you would have provided us with information that you didn't provide in June or December to us, we could have made a different decision, and we may have made a different decision. But you sat there and didn't say a word.
I would say we did not realize at that time that the 5% was unknown.
You didn't realize that we didn't know that 5% was unknown?
There was a presentation made in February, the prior February, where the 5% was discussed as part of the clinical criteria.
Well, I have that February meeting.
Page 66.
Well, I have page 32 and 33. And that's where you all talked about the cost of those. You never said anything about 5%. I went back and looked at my notes. You did not say anything about 5% in February.
Commissioner, we have other
Okay,
commissioners. Okay,
I'm done.
All right. Commissioner Sutton.
Thank you, Mr. Chair. In my recollection, there was no continuation discussed as to what the parameters were for re-prescribing, and so I'm not quite as worked up on that. Although I think that is something that the body needs to consider, perhaps moving forward. But I do want to clarify something. I want to make sure I understand correctly. The 5% is each time they go to renew, or not, or is it they're from 200, they're at 190. So long as they stay at 190, they stay on the drug, or is it 5% each time?
It's a loss and maintaining of that 5% from the original baseline. So in that example from one at 200, from 190, as long as they maintain or improve that 190 through the course of their life, they could continue to be approved.
So it doesn't have to be like for the next year, 180.
No, sir.
Okay. Yeah. I think we might need to fix that part. All right. All right. Thank you very much.
Okay, let's walk through. I have some questions and comments that I'm going to reserve till the end. I want to walk through a couple of different scenarios, though, because they're just to clarify for everybody. So you talked about somebody coming in today, brand new, never having received a GLP-1 for AON utilization, and you walk through somebody who was below a 35 and somebody at 35 or above, which we just discussed. Let's walk through if somebody had started in August, for example. Same two scenarios, somebody below a 35 at that time, but would have been approved under the pre-existing criteria when they get to today, and then somebody who was above a 35 coming into today. So both of those, please.
Yeah, so this is happening real time right now. So if the doctor had attested that their baseline BMI in 2025 was 34 or below, they would be denied through prior authorization at reapproval underneath this new criteria. If the doctor had attested their baseline BMI was 35 or higher in 2025, then they would be approved only if they've met that 5% weight loss threshold. So we reached out to members that had a baseline BMI of 34 or below, sent letters, let them know they'll be getting prior authorization in 2026. And we've already seen about 700 prior authorizations reviewed this year, and we've denied, I think it was 53% of those because of the BMI threshold. I bring up those two numbers because when you look back at 2025, we were only denying 10% of our PAs due to the previous criteria. So for the entirety of last year, we had 500 PA denials. Overall, these are straight PA denials. These aren't walkaways. These are nothing. They're straight PA denials. We had denied about 500, and this year, through early February, it was 375 PA denials. So, and that's where the savings that we had talked about. And that's, again, this is the program that we implemented associated with the program with the savings of $2 million that we quoted. So the savings comes from PA denials for people that don't meet the current criteria. So we've already seen good results from this.
Questions on those scenarios?
There's an additional scenario. Do you want to go through another?
Sure, if you've got one.
I think when it comes to continuation of therapy, there's another way to look at it as well. Member comes in today, their BMI is 50. We'll say they weigh 300 pounds, right? They're approved for this medication. When it comes up for reapproval, they have not lost any weight, or if they have lost less than 5% of their weight from the 300 pounds they weighed initially, they would not be approved under this current criteria. So even though their BMI was 50 and still 50, the member's not approved underneath the continuation of therapy. So the doctor has to, again, provide us the chart notes for their BMI and provide us their weight at the initial start of therapy, and then their weights when they're going up for reapproval. And if that member had not seen any weight, they would be denied for reapproval.
So in that scenario, the initial approval is BMI specific, and that's it. That is
correct.
And
Yes,
then when the PA comes up for renewal, the 5% is controlling over the BMI.
Correct.
And if that member is denied at that point in time, how long do they need to be away before they can reapply for that and have the BMI become controlling again?
At that point, the member could appeal. I mean, you mentioned appeals before, so members can always appeal a PA denial. But how long they have to go through reapproval, I don't have that answer.
If they were in your scenario 50, weigh 300 pounds, they did not lose the 5%, they came up with a PA renewal, they're being denied because the 5% continuation of weight loss is controlling at that point, is what I'm hearing. They're denied. Let's say they lose the appeal. I'd be interested in the appeal process. How long before they can come back to the doctor and go through the PA process and have it approved based purely on BMI? Is it a 30-day wait, a 60-day wait, a 12-month wait, or is it the rest of their life? That's it. We know the answer to that question.
I do not.
Do you understand the question?
Yeah, I do. Yes. Yeah. If it's just immediate turnaround or appeal or not, PA or not. So I do not have the answer to the question right now.
That'll be, I think, critical information for us to receive to be able to distribute to our members.
Yeah. we can get a response on that. Yeah.
That'd be helpful. What does the appeal process look like? You mentioned the individual who could go through the appeal. If they only lost 1%, 2%, 0%, whatever percent, they're denied because the 5% is controlling over the BMI threshold. What is the appeal process and what's the decision tree look like?
Sure. There's a first level appeal and the second level appeals. First level of appeals looks at to make sure that we denied based on the correct criteria. The second level is clinician to clinician. So we'd have an expert in the field review the information that the doctor sent, and the doctor would state their case. And if there was a reason why they couldn't have lost the 5% weight, I mean, I can't pontificate on why a clinician would approve an appeal, but we do track those appeals. They are included in, any decrement of savings that we have. Because if a member is denied for a PA, we count if they had the appeal approved, that reduces the savings. So it basically goes from an initial review of that we made sure we met the criteria, and then clinician peer-to-peer expert in the field is a second level level appeals. So just the standard appeals process we have for any medication. So.
Commissioner Schmidt?
It's a qualification of the peer-to-peer. Who is the peer on the other line? Who's the clinician? An MD, an APRN, a PA?
It is an MD, yes.
A what?
It is an MD, yes.
And an MD in bariatrics?
I can positively confirm that for you.
You know, a pharmacist could answer all these questions for you. So can you start texting back to your office and find out Adam's question and my question, please? I know they're working. Please?
Yes, I was taking notes. We will reach out.
Asking you to get the answers now.
Okay. Would you like me to step aside and make phone calls? I'm just trying to.
Yeah, I think as we move through the request is if there's somebody in real time that could answer that as we move through the next section and then come back after that for an answer, that'd be helpful. I believe that is the question.
Understood.
And if not, I would, next day response would be the next best thing. Okay. So, full transparency on this, Commission. This was brought to my attention a couple of months ago, or I don't know, a while ago. So we've had a few phone calls on the topic, which is how I ended up on this. I know I was confused, and I know that it didn't track exactly with how I thought the motion worked last time. I also went back and reviewed, had my legal team go back and review and see where things are at. I did express my frustration with the Caremark team, and just for any vendor who is under contract with the state, my expectation is that folks are in the room, and if there is discussion or information that you have that is material to the discussion happening, even if you're not on the agenda, even if you're not called upon, flag staff in the front row, flag me, flag somebody. The time to have the discussion is during the commission meeting, not after the fact. We need to make sure the information is given to the commission so we can make a well-informed decision at the time we're making the decision instead of having these conversations on the back end. So I've expressed that with the two vendors that I spoke with on the phone. I don't think there's any lack of clarity on the expectation moving forward. So that should be the expectation as we move forward. It's critical. We have a dual mandate here as commissioners. We are to design a robust health plan coverage for our employees and those that piggyback off of it, also with an eyeball on the state's budget. Both are equally as important. We had the discussion based on seeing what a $2 million savings would look like. I believe my vote was based upon an understanding that is a little bit different than what we're discussing today. So I've made clear my expectation of all vendors, specifically those at the podium right now, that the time for this discussion and to come forward would have been back in June. Just want to make sure I had that on record. As it relates to how this is being operationalized, the information that was provided by Caremark to our consulting actuaries, whether we knew about it or if it was discussed or not during the June meeting, did include the mechanics of this. We can disagree on the mechanics and whether we agree with them or not. So the legal analysis suggests that we can maintain this, and it is in concert with the vote that we took, because the vote that we took was based upon the information that Siegel showed us with a $2 million savings, which was informed by the Caremark that had this in place operationally. So we can move forward with this, and no motion is needed. We can discuss whether that's the right thing to do, or if we want to talk about plan design changes at the June meeting for plan year 27. The risk of doing anything different today is we've calculated rates, I assume, based upon what was decided in June and what's being operationalized today. So if there's any modification right now, you're looking at changes to the employer contribution, the employee contribution, and how this is operationalized. So I just want to make sure. Does anybody have any questions on that nuance real quick? If I can come to Commissioner Sutton first.
Thank you, Mr. Chair. And when we were discussing the numbers ahead of time, I believe that we did achieve the $2 million savings. If I'm so in that, at least our financials are correct, even though the implementation may not have been exactly the same way we thought it was going to be. So I mean, on that front, at least I think we're pretty solid. I think moving forward, we probably ought to more clarify our renewing the prescription standards. Whether is it okay that if they continue to lose weight, we keep them on? I don't know if that's our intent or if once you drop below 35, either way, I'm fine as long as we specify what that is. And but financially, I think our expectations have been met. So in that regard, I think we're fine. Thank you, Mr. Chair.
Thank you. Commissioner Schmidt.
Well, I'd like to agree with you, but I can't because
I'd like to be happy about that, but I can't.
I know. And I appreciate what you said. First of all, I want to say that how can we let this go on the way that it's being, as you say, operationalized, when that was not what the motion we made here. We made a very clear motion. You have a BMI over 35, you get the GLP-1s. And so your that of the person that has a BMI over 50 doesn't lose the 5% and then gets denied makes absolutely no sense. That is not what the commission intended either. So how can we continue on this train when we have in our minutes and in our meeting what our intent was, and it was not it? I mean, you know, it's no secret I didn't vote for CVS to get the contract. And I remember Commissioner DeCant saying, if we come up with, if Caremark isn't doing their job, we will end the contract. Well, they didn't do their job, and they're not doing their job. They did not execute what we unanimously voted on.
Commissioner Deckent, you have a look.
Well, my
Microphone on.
recollection is not nearly as good, and I can't recollect clearly one way. I have in my mind, did we not expect that there be some weight loss or some progress made by use of the GLP-1? And I'd love to go back. I may even try to go back and listen to our conversation. What was our motion? Can somebody quote it, read it? I mean, what was our motion that we voted on?
I do not have that in front of me. I have gone back and watched the video. I think well, I don't want to say the wrong thing. It was around putting a threshold of 35. We were, I do recall explicitly, we stated no grandfathering, meaning if somebody was meeting the 2025 criteria of it at a 32 with a comorbidity and was on a GLP-1, they would not automatically be covered, which that part is being operationalized correctly. It is when it drops below. There was a discussion that Commissioner Schmidt led that said if somebody's above a 35 and then they get below a 35, what happens? I don't know that we ever came to a direct and concise answer, but the motion had to do with setting a threshold of 35, I believe, as presented, which is as presented is kind of the technicality that could allow us to continue, right, wrong, or otherwise, allow us to continue on this path. You have a follow-up?
Not a question. I'd like, could we all be given access to the video so that we, or
it's on the Department of Administration website.
Just go to the DOA and
I can give you the link after this. Yes.
Afterwards.
You go to the State Employee Health Plan and the Healthcare Commission and then meetings, and you can watch the video. I can even give you the timestamp of the discussion.
I'd appreciate it.
And I think staff is maybe looking for the actual motion now, but Commissioner Schmidt.
Well, I find it interesting that I received several emails from state employees who would have been caught, so to speak, in that, like, BMIs of 30s that have, wanted to continue. And it's kind of interesting to me that our state employees that listened to our discussion were very unhappy about our discussion and understood it more than CVS, who is the expert. I think that's very telling, that when our own employees can understand what we said, but yet we can't implement it.
And help me then, the implementation, what's incorrect in the implementation, the application of the weight loss?
It's if I may, so what is incorrect, or what we're discussing, is a scenario in which somebody comes in at a 35 or above and is approved, because we set that as the baseline. When their PA renewal comes up and they are below a 35, what I'm hearing from the commission, and certainly my thought, was they would no longer be eligible for utilization of the GLP-1. It would not be a covered service. What we are now learning today and discussing is that even if they're below a 35, as long as they met this 5% weight loss threshold, they could continue the GLP-1 therapy. That's what's at conflict.
I guess my question would be then, can that happen? In other words, can I have the weight loss and not see a change in my, or can I have the weight loss and still maintain a 35 or higher BMI? I don't know the answer to the question, and I would assume it would take a doctor or a specialist, but I would assume there's a relationship that if I lower one element, the other element usually would come down. I don't know that to be accurate, but I would expect that to be the case.
It's accurate.
In which case, if well, I'll stop there. But that's what I would expect, and I would like to know, is that an accurate?
That is
assessment?
accurate. The BMI is a formulaic. It's formula driven.
Right. That includes weight.
That includes weight
and
driven by
other
weight.
body metrics.
Height.
Yeah.
Commissioner Schmidt.
Well, I think that's an interesting question, because a person could have in their last example, a person could have a BMI over 50 and lose 5% of their weight, like the 300-pounder lose a 5%, and then never lose another pound and have their PA approved in forever if they'd lost that initial 5%.
Which you might think, if they've got a BMI of 50, they ought to continue to stay on it, but if they don't lose the 5%, they would be eliminated.
Right. And then they don't know how long that it would take. Because, theoretically, you could go to the doctor the next day and you didn't lose your 5%, so your PA is denied. I'm interested in the peer-to-peer, because we have laws on our books on our independent medical review where our peer-to-peer have to be in the same specialty and the same subspecialty in order to get the PA, and when we go through an independent medical review. And if you're denying them for not medically necessary, which I would assume is what you're denying them with, all of our state employees are eligible to go through that independent medical review process. And for anyone listening, I would encourage them to call the insurance department. We'd be happy to help them through that process after you get that second denial. But I think that you could theoretically come back in the office the next day, your BMI would be above 35, and you can just get on it. Why would you even do the denial process? Because your BMI is over 35. This just doesn't, who does CVS work for? I thought you were supposed to work for us at the state, but who do you work for right now? Who do you represent? It's not a rhetorical question.
I work for CVS Caremark. Yes.
You work for CVS Caremark, and for their rebates and all of that stuff? That's what you're telling me?
Commissioner, I think that
I know, it's
we're out
rhetorical.
of line here. Let's stay on the topic if we could. Okay. Commissioner Sutton.
Thank you, Mr. Chair. And I'm pretty good, but it's a little bit of a stretch for me. But in February, I'm doing this from memory. I'm going to have to look it up for sure. But there was discussion about Caremark or monitoring continued prescription on the GLP-1 program. And it talked about calories and exercise or something. And then it also said Caremark also requires a 5%. I would have thought that meant 5% cumulative, 5% each time, but it doesn't say that. We had that information as I'm recalling. I know there's some element of doubt here. It's been a spell, but it seems like there was discussion of that. Although I do think it may have been interpreted differently than I would interpret it. But I just think this is something that we need to clean up on our end as far as our expectations. We need to fix that. And I think it is something that needs to be fixed. Thank you, Mr. Chair.
Thank you, Commissioner. Yeah, we did have a pretty long informational discussion. I think Eileen, who is here behind the podium there, walked through a pretty educational session with us, but that was at a previous meeting and it was informational only. I think it's very clear what is being discussed here today is when the discussion was happening at the June meeting, or Mayor June meeting, we were doing plan design. If there was information that was relevant from a February discussion, it should have been brought forward to the June discussion as well for clarification at that point. I think that's where the rub is that if we made a motion that was in conflict with the information that was provided previously, we needed to be corrected at that point in time. And that's all I'm saying. So, Commissioner Kane.
I don't recall the exact conversation either, so plan to go back and listen to the recording. I guess just in listening to the conversation this morning, I've talked to several state employees about the GLP-1s. And so thinking of a person with a BMI 35 and then they lose weight and are a 34 and it won't be approved anymore, like that's still not a healthy weight. And I feel like we lose that investment that we've already made in having them lose successfully. And so, I mean, I think that's an issue. And I know we've discussed it and decided on it. But I've talked to many state employees who are really struggling right now, who are on GLP-1s. The cost of Wegovy has more than doubled for state employees this year. And I'm not sure all of the particulars of that. I would be interested to dig into that more about why, but they're already struggling. I talked to one who stated like she wasn't going to be able to take hers weekly anymore. She was going to have to go to every 10 or 11 days to make it last longer. And so we don't want them not using it as prescribed. And so I just really have concerns about making this available to state employees. And I believe that research shows that when people stop taking GLP-1s, they gain the weight back. And I don't think that's our goal either. Thank you.
Thank you, Commissioner. Third, Commissioner Sutton.
I'm sorry about this. This one was off the topic of this particular topic, but it still does apply. And this one would be more for Caremark rather than just a discussion point. So you can. There's been increased chatter regarding the use of GLP-1 drugs for treatment of addiction and this sort of thing. Is that something we should be concerned about here in the committee? Is that something that's being done currently, or is that just talk as far as getting approval for it is concerned?
Wegovy is currently approved for cardiovascular, sleep apnea, and NASH. It's a medical illness. It's not currently approved for anything beyond that. But the pipeline is rich with contraindications, with additional indications for these medications, so they're not going away. There's a new not a GLP-1, but there's a new medication coming out, Lilly, we think in the next few months, or fligliperon, I'm sorry, as well. So the pipeline is rich. So Unfortunately, the spend is not going to go away. And then Wegovy tablet became available. It's about a month ago as well, and that's came in at the same price as the injectable Wegovy. So it's not currently approved for anything beyond. Wegovy is not currently approved for anything beyond the NASH, the CV, and the sleep apnea, but the pipeline is rich, and there could be additional approvals for this medication.
All right. Well, given the price tag of this stuff, I think that's something that
Excuse me.
the body ought to be looking at. Thank you, Mr. Chair.
Commissioner Schmidt.
Thank you. I want to make sure, I've done some rough calculations and I want to see if maybe Siegel would agree with rough calculations. So if we have a $20 million spend on GLP-1s, approximately, we divide that by our 38,000 member lives, and then we divide that by 12. Every state employee is paying over $40 a month for coverage of the current GLP-1s at the current rate we have now. It's only going to go up with the guidelines that CVS has, the unauthorized way that they have decided to do this. And I'd just like to point out one thing that, you know, I've abuse of prior authorization without checks in place, we will not be able to sustain further rate increases for our state employees if we have abuses of that. And it increases the cost for everyone, and it'll decrease the benefits in our other places if we don't have a check on our prior authorization process.
As it relates to the calculation there, my request of Siegel would be if you can find that calculation and identify exactly, if you have it readily available, great. I would expect to, if you can come to the microphone, please. Can you, Melanie, if you can come up, please, and identify yourself.
I did verify your math, the 20 million and the 38,000 divided by 12, that does come in right around $44 per month. And I don't have total GLP-1 spend through the end of the year. The latest I had was through September for total GLP-1 spend. At that point, it was about 14 million. If you were to complete that for the year, you would expect about 18.7 million in total spend. I do know the AOM spend through the end of the year was about 12 million, just the AOMs. And that's really the piece that is a discussion here, is that 12.
So if we can, for the next meeting, or actually before the next meeting, if you can send follow-up to staff and we'll distribute it to the commission, identify exactly what the AOM spend is or was for calendar year 25, what it's projected to be for 26, and what the PMPM is, both for the state and for the employees.
And just for the record, my calculation did not include the Part D Medicare, because they're under a completely different prior authorization. A pharmacist would know that. Thank you. Thank you.
Okay. Commission, I need to move us along here based on time. I think we had a robust discussion again based on how the motion was stated, how things are moving, and the projected cost avoidance that we are achieving in calendar year 26. I do not believe a change at this point is necessary. But certainly something that we should be discussing in much greater detail at the June meeting as we talk about plan design for this and any other plan design changes that we're going to make. So I'm going to, Commissioner Schmidt.
So, Mr. Chairman, does that mean that we're going to allow the current PA process to go on? Because I'll register my adamant no on that. We have to give, now they have put us in, CVS Caremark has put us in a position where any changes that we make back to what we even if we decide we want to go back to what we originally said, we have to give 90-day notice because they have messed up. They did not implement what we asked them to implement. And, you know, and I really think their contract ought to be terminated. I'm sorry, but this is a big mess up and this is huge. You know, I don't know, it's about $4.5 million per quarter. We're approximately what we're spending on GLP-1s. This plan cannot sustain that. We cannot.
Any other discussion before we move on?
Just one question.
Commissioner Decken.
So you're saying our expenditures for GLP-1s will be higher based on the weight criteria overriding the BMI. Okay.
I believe
I'm
that,
saying
one
that-
second, please, Commissioner. I believe, and I need Siegel to correct me if I'm wrong, the way it's being implemented, which we all disagree with, I think, up here, are we achieving the cost avoidance number that Siegel had projected past last June? And if you can come to the microphone and answer that question directly, please.
Yes, the $2 million that was provided previously was based off of the Caremark criteria. And I would ask them to verify, but I believe the issue with eliminating the continuation of therapy is that it would put the rebates in jeopardy from the manufacturer's perspective. And I believe would result in an increased cost to the plan because of that loss of rebates. But I would ask them to verify that information.
Can you verify that, please? Yep.
Yeah, you're saying if we remove the continuation of therapy?
Yeah, if we went straight 35 and that was the only item for PA.
Correct. Yes, that would result in the full loss of rebates for those medications.
And that amount is?
When we quoted it in July to Kansas, it was about $10 million.
Commissioner Schmidt.
So that's very interesting to me. The Kansas legislature passed a bill out of committee yesterday on PBM reform that says all rebates have to be returned to the plan. And the SCHP is included in that.
And it wouldn't be a loss of rebates that we just wouldn't give you. It'd be a requirement from the manufacturer. They would no longer pay rebates. So there would be no additional rebates to pass to the plan. The manufacturer would not pay the rebates to us for us to then pass them through.
Why is that?
It's their criteria. They make the product, they set those rules. It's their.
And so they
criteria.
decide, so they determine how much they're going to do. And they say, oh, if you use more of our product, we're going to give you a whole bunch more rebates. That's the way rebates work.
If I can interrupt real quick. We need to maintain order and decorum in here, please. So if you're asking a question, please ask that to be identified and please wait for the question to be finished before you respond. Go ahead.
The manufacturer sets the criteria on how they will pay rebates. And we either have to meet that to get the rebates, or if it's not met, the rebates are not payable by the manufacturer.
But Mr. Chairman, we do decrease our spend.
If you went with a strict 35 BMI only, no continuation of therapy like you have today, then the manufacturer would no longer pay rebates. That would increase your cost because you would no longer have those rebates offsetting your cost for those products.
I would like to see that. I would like to see the language in the contract that says that. And I would like to know how come nobody said that when we were talking about rebates. We had a whole discussion when we had our awarding of our contract on rebates. Nobody from CVS Caremark stood up and said that, and you were apparently here.
Commissioner Sutton. Okay. All righty, so we have a follow-up then to get the contract language on the rebates. Commissioner Sutton.
Sorry, I did want to clarify something. That was the Senate. It hasn't come to the House yet. Okay, I just wanted to make sure. You said Kansas legislature. So oh, don't lump me in with that.
I said it came out of a committee.
Right. Yeah, it was the Senate. Yeah, thank you.
All righty.
May I?
Commissioner
Well,
Decken.
I know you're trying to bring this to an end.
I am.
The Siegel comment, I want to make sure I understand. So the 2 million savings that we were anticipating is occurring as best we can tell at this point,
Correct.
based upon the application as it's now being made.
Correct. Yes, the $2 million was based on the current criteria.
And if we change the criteria, then we would see a decrease or a loss of rebates. Is that?
Depending on how
correct?
you change the criteria, but if, as discussed, we were changing the criteria to eliminate the continuation of therapy clause, then it would result in the loss of rebates, which would then result in a
An
cost
overall
of the plan.
increase cost.
Correct.
Thank you. Okay, Commission, I am going to move us on at this point. We're going to move on to item number 4, which is a Health Quest Health Center. It should be in tab 4 in your books. And Director Flory, are you walking us through this, or is this somebody else?
I can, yes.
Apologies
So-
if I put you on the spot. But go ahead.
So Pete, let's go to the next slide. So we have been advised by Marathon that our current MD, Dr. Blaker, has put in his resignation and he will be leaving the clinic as of May 29th. He will be returning to the East Coast where he has family. So we have begun the recruitment process. Actually, Marathon has begun the recruitment process. The position has been posted. They are utilizing medical boards. They're utilizing recruiters. They've done outreach to like the Association for Family Practice. They've done outreach to, there was a hospital down in Wichita that closed that had some potential providers. They've outreached to reach those individuals to try to get applications. At this point, they have a signing bonus that they're offering for that position. They prioritized it on a recruitment board called Two Ladders. They have a campaign with Find Them and Indeed. They've reached out to the Kansas Board of Medicine and the Kansas Academy of Family Physicians. They are collaborating with a recruiter that specializes in military personnel to try to see if we can reach maybe a potential candidate that might be transitioning out of the military. They're doing a number of discussions with providers that they have used like in a locum basis in the past to see if any of them would be interested in taking the position. They've contacted Stormont Vale, Oak Street Health, and Oasis Family Medicine to see if there's any interest there. So we are robustly working on trying to get another provider, but should a provider not be available by the time that individual leaves, we do have a contingency plan. And that contingency plan would be for them to bring in a full-time locum MD. They will assume the increased cost of that provider until they can get a full-time provider on site. And we are looking for either one full-time provider. We would be open to two if they wanted to have one work 3 days and one work 2. We're trying to be as flexible as possible to get MD coverage for 5 days a week because we have seen in the Topeka market that the number of available providers is very small, and we've just struggled. We struggled getting Dr. Blaker, and so they have really learned a lot from the comments of the commission as well as from their experience, and have put together a robust campaign to try to get somebody back on site as quickly as possible.
Thank you very much. Appreciate that. Any questions, Commission? Commissioner Schmidt.
So in the past, we have had many weeks without physician coverage.
Yep.
Right?
Yes.
And why didn't they get locum tenens for that? Why did we allow them to go without MD coverage?
Sorry, breaking my own rule. If I may, I think if I'm not mistaken, we've had this discussion before, and this is in part trying to correct that and make sure that on the go forward, this is a remediation plan that Jennifer's trying to present to us, that we've made it clear to them that there shall be no lapse in coverage. We need to have MD coverage there. And this is what Jennifer is walking through to ensure that does not happen again this year.
Okay. And then, I just Googled some things on Marathon. They have 750 plus health centers nationwide. They say they have 1,200 plus care providers, and they're in 41 states. Why can't they transfer somebody into here?
Not a question I can answer, but as Jennifer has laid out, there is a plan to ensure that there is MD coverage here.
Well, I would respectfully ask that they add into their plan transferring somebody here, because they profess that they have all of these providers, and I just, they have providers that work for them, and sometimes people have to transfer into places maybe they don't want. Thank you.
Okay, seeing no further discussion. All right. Would draw your attention, Commission, just to the appendix materials that was follow-up from the last meeting, specific to the ITDM contract, technical support, and what the cost per hour is. That's not expressly identified in the contract. So assuming there are no questions on that information, Commissioner Sutton.
Thank you, Mr. Chair. This isn't a question on any of the appendix materials, but I do have a request for Siegel. If it's possible, certainly before our June meeting, to put together a kind of, I'm not sure what the term, cost benefit analysis, I guess, with the hardline 35 stop on renewals of prescriptions versus the loss of rebate. I'd like to see, maybe we'd save more money even with the loss of rebates. I just don't have enough information to make that determination, and I think it might be kind of valuable a little bit down the road.
Yeah.
Thank you.
And I'll note on your agenda here, we have the next meeting date is April 15, 2026. The one after that is June 2nd of 26. Those are the dates that we agreed to last year for the year. It is the June meeting at which we will be doing plan design for 2027. So my recommendation would be to get any ideas starting now, not just GLP-1, but anything else, and start thinking about what you might want to have Siegel model. The sooner we get them the information, the better. But certainly by the April meeting, we'll need to be able to provide them with what we'd like modeled so we can have that in advance of the June meeting. I would also, in my personal opinion, as we look through the financial model that was discussed earlier by Siegel, we're getting pretty low in the reserve. So as I mentioned earlier, we have the dual mandate. We do have to provide a robust coverage for our employees and those that piggyback off the plan, but we need to be mindful of the state budget as well. Which is near and dear to my heart, obviously. But a $13 million cushion is, you could have a bad month of claims and run that entirely out. So again, we need to make sure that we're taking care of the plan for everybody and ensuring that it's solvent going forward and it continues to be a benefit for our employees. Commissioner Schmidt, did you have a question?
I have two follow-ups if
Yes.
that's all right. One is on the plan design, if Siegel could provide us with the cost of per member per month of what, like when we increased the orthodontia, what was that per member per month increase so that we can look at what it is for that. The other thing I would like follow up on is I attended many hearings this past couple of weeks, and in one of the hearings, it was said that the zinc issue that we had with the rebates, it was my understanding when we got the 14 million or whatever it was, that was for retroactive. And when we asked, had it been fixed going forward, it was kind of fuzzy on if we had fixed that. It was said adamantly that the rebate was fixed. I'd like to see the contract that I want to know how it was fixed, because it was my understanding that was just retro and not moving forward. So I want to make sure that zinc isn't going to, I don't want another rebate in 2 years for 30 million of rebates that we didn't collect and we didn't have interest on.
I would agree. I'll have counsel reach out to the Attorney General's office. Quite candidly, I don't think we've received a whole lot of information or communication on that front. So that's not running through our shop. That's running through their shop. We can only report back what we get from them. So we need a partnership from them and a willingness to communicate from that office to our office to tell us what was or was not agreed to. And we'll have that follow up in writing. Come on up. We have a request to address the committee, please.
I just want to be sure we're
Microphone
crystal.
on?
It is on.
Okay.
Can you hear me?
Yes.
I just want to be sure we're crystal clear on the request that you just made for the PMPM. Was orthodontia just an example? And are you saying when we show savings for all different plan designs, you'd like to not only see the full savings, but the PMPM next to it?
Actually, it's probably the reverse. It's not the savings, it's the expenditures. We went from like $1,000 to I think $1,500. So what does that $500 mean in a per member per month increase in what we're increasing for our employees?
Okay. Any plan design changes you want to see as a PM? I got it. Okay.
Thank you.
Thank you.
All right. Seeing nothing else, I would readily welcome a motion to adjourn. We have a motion by Commissioner Kane. Is there a second?
Second.
Second, Commissioner Decken beat you. All in favor, say aye.
Aye.
Any opposed? We are adjourned.